if you're really treating the pelvic floor and it's like kind of getting narrow and working on pelvic floor strategies, sometimes that's too focused on this region, especially for hypermobile people. Don't forget to zoom out, because sometimes you could be trying to relax their muscles, but if they've got a POTS issue or a mast cell issue that's driving the pelvic pain, you can keep teaching them to relax, but really they actually might make some bigger gains if you help get support for them in those other health considerations that actually might be a bigger driver.
Welcome back, every bendy body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes dedicated to helping you navigate joint hypermobility and live your best life. I am so excited to have Dr. Brooke Winder on the show today. Dr. Winder and I have presented together at multiple conferences, and we've gotten to hang out and just chat about all things pelvic floor, joint hypermobility, high-level performing athletes, and everything in between. Dr. Brooke Winder is a pelvic health physical therapist and dance science expert who helps performers optimize movement, manage pain, and navigate hypermobility. She serves patients through her clinical practice while teaching at California State University, Long Beach, and is widely published and sought after for her work at the intersection of pelvic health and performance. This conversation today is so important because joint hypermobility, pelvic health, and sexual health are so interconnected. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. I'm so excited to be here with Dr. Brooke Winder. Dr. Winder and I have had the great pleasure of presenting together a few times and working on some projects together and everything. So it's high time that we had you on the show.
Wonderful. Thanks so much for having me. I'm really excited to be here.
Good. Well, of course, you're a pelvic floor physical therapist. You're also a professor. You work a lot with dancers. You do so many different things. We're going to talk about all these different fabulous, like interconnected, interwoven topics. But let's start out by talking about like how you started noticing these patterns of pelvic floor dysfunction in dancers. Because of course we see that in hypermobile people, but you started noticing this in dancers also?
Yes. Part of it was actually my own experience when I was young. So I grew up dancing, but prior to really picking dance as my main activity, I was a competitive gymnast. And it was actually when I was doing both dance and gymnastics in my early adolescence, kind of through mid-adolescence, I noticed in particular that I would leak sometimes. I would leak urine. I never told anybody because I found it really embarrassing. And I thought, I have to be the only person in the world who's experiencing this at my age as a teenager. And I never really understood why that happened. It didn't really have like a particular pattern to it. And then it got better as I got older and kind of finished through puberty. I wasn't doing gymnastics anymore. So it was something that really wasn't on the forefront of my mind, seemed to resolve. But then as I started my physical therapy career and I started working with pelvic floor PTs, because I really started out very much in the ortho side of things, I saw a lot of people, including dancers and other performers, who had low back and hip issues. And then I really realized that there was this whole area in between the pelvic floor region that it was very common for people to have symptoms there. And the more dancers I talked to, I realized, oh my gosh, I was not the only one that was going through all of this. So that really kind of struck my interest once I started working with pelvic floor PTs. And then I decided to get trained in assessing the pelvic floor as well as working with orthopedic conditions.
And I think it's so terrific what you're doing. And for all the pelvic floor physical therapists out there, I just want to say thank you, thank you, thank you, because as I'm married to a urologist, as I know that you know, and even though he's operated in that part of the body, in the pelvis, in the male pelvis, I think most physicians do not understand the pelvic floor like at all. So God bless you to all of you pelvic floor physical therapists out there because we need you so desperately. And we know that hypermobility also impacts the pelvic floor. So tell us about that.
Yeah. I mean, as someone who works with dancers and I also work with aerialists who work in the circus world, um, I work with a lot of hypermobile folks. And when we think about sort of that hypermobility pelvic floor connection, um, generally there's just a higher prevalence of pelvic floor types of symptoms in people who are hypermobile. So, typical symptoms of pelvic floor dysfunction can be things like leaking urine or incontinence, can be pelvic pain, and that can include lots of different types of pain that we can talk about, but can include genital pain, pain with sex, painful menstruation, as well as symptoms of pelvic organ prolapse or pelvic pressure, or having to urinate really frequently with a lot of urgency. So, those types of symptoms if someone's hypermobile, particularly if it's a genetic hypermobility issue that's affecting all of their connective tissues, they do have a higher prevalence of these experiences. And there's lots of reasons that we think that's happening, kind of related to the sequela that could be associated with hypermobility, as well as kind of from a biomechanical standpoint. Potentially people who have less passive stability in their connective tissues, their muscles might need to be working harder or more frequently or more consistently to try to help the body feel stable, and perform with people I work with perform high level activities, and so that is one of many reasons why there could be uh, more issues along the pelvic floor.
So if their ligaments are not able to kind of hold them together with ligaments which connect bone to bone, then maybe the muscles are getting hyperactive in order to kind of try to hold everything together.
Yeah, so I mean, I think we continue to need more research to really help us demonstrate this. When we think about things like how much tension is in the pelvic floor. Um, but as an example, let's say you have more mobility available in the sacroiliac joint or more mobility available around your pubic symphysis, around your pubic bone, or just across the pelvis, or even at the hip, because it's so nearby, has so many fascial connections, then it would make sense that the demand on your muscles is ramped up a little bit. And so the pelvic floor muscles could be having more difficulty relaxing, or maybe they're getting fatigued or just having to work harder or hold more tension in order to compensate for that and help with the stability of the surrounding joints.
So does that explain why people can be strong and high functioning, but also have pelvic floor dysfunction?
Yes. Yeah, so it's one of the reasons that I think it can confuse someone who is a really high functioning athlete, let's say, like the dancers I work with, where they're strong, they move all the time, their hips are strong, their body is really um, well conditioned overall. And so it can feel really confusing if they're experiencing something like leaking, because I think we tend to understand that. Um, Maybe as being something that is, okay, that's a weakness issue. If I'm leaking, my pelvic floor has somehow become weak. And we see these issues in hypermobile people, in dancers, and lots of high level athletes and performers, not just dancers. We see these issues even before there might be more of a risk of the pelvic floor becoming, strained or having trauma to the pelvic floor, like with pregnancy and birth. So even people who have never been pregnant, never had a baby, can have these issues as high level athletes. So that potential that maybe it's a tension issue or a challenge with relaxation can be some reasoning why higher level athletes might have this going on. And then there's a lot of other factors. in terms of their load and demand, just repetitive impact that can be a factor, as well as nutritional issues in terms of fueling that could be also kind of overlaying with that.
Yeah, that's such a paradox that they can have this, lax connective tissues, but have this increased muscle tension. And I totally agree with you that most of us, when we think about urinary leakage, that we think, oh, the pelvic floor is weak.
Totally. And it's not always the case. Sometimes it's a coordination issue or a tension issue.
And we're going to talk about Kegels. Is that how you pronounce it? Kegels? We're going to
Kegels
talk
or
about
Kegels.
yeah, we're going to talk about that later because I feel like so many people, they think pelvic floor equals Kegels. And it's like, no, there's so much more to it than that. So,
Yes,
yeah,
exactly.
we're definitely going to talk about that later. So, why do you think hypermobility issues are so often missed both dancers and non-dancers?
Um, I mean, in particular, I think hypermobility in general is still something that's not widely understood. I mean, hence why you have this podcast. And so I think a lot of people who have hypermobility and they have all sorts of symptoms that aren't just about, having a bigger range of motion at your joints. They've got issues that are affecting them throughout all of their body systems. If it's not really well understood, they might be going to different doctors, different physical therapists, different healthcare practitioners for all of these different issues without realizing that it might be connected. And so I think it can easily be missed in that sense. And then for our dancer and our performing artist population, um, it's so common to be bendier. That's part of what uh, our our sport demands in dance is big ranges of motion kind of throughout any type of dance genre you train in, from ballet to breaking to contemporary dance. There's so much demand for high mobility that I think a lot of people who end up in dance and enjoying it can move into those ranges easily. And so I think because it's so common, we see it all the time, I think that also makes it harder to recognize that, yes, that can be an asset for you, but that person who's working at this really high level and doing these amazing things and can move through all this range of motion might also really be needing a lot of support in other ways with symptoms that they're managing and how they're approaching their craft. But it's very hard to notice when it's just such a common thing.
And also, comparison is so common, right? So, Jennifer Milner, who of course you know as well, very, very well, she and I interviewed Skylar Brandt, who's a principal dancer, of course, with ABT, and she's talking about how she's not hypermobile. Well, maybe relative to Chloe Missildine or some of the other people in the company, maybe she's but she still has more range of motion than most people. So they're comparing themselves to each other because, of course, that's who you're looking at all day, every day. So you don't really know what quote normal people look like. So I think that's the other challenge that dancers have at that elite level is the bar is just changed dramatically for them.
Yeah, especially, as the years go by, it just kind of, we keep pushing the envelope. And I think that I see the same with some of the aerialists I work with too, where they see a lot of times they're saying like, I'm just not flexible enough because they're maybe working with people who are a lot more mobile than they are. But yeah, exactly. In comparison to the general population, they have high mobility.
Yeah, exactly. Okay, so let's talk a little bit about your research. You did some very interesting research on dancers, urinary leakage, and I don't know if you covered pelvic pain at all in there or not, but what was some of the key, a little bit, okay. What were some of the key findings from your research?
Yeah, so my colleagues, Carrie Lindegren and Amanda Blackman, and I did a study a couple years ago. It came out, and we looked at a little over 200 professional female dancers, and their average age was kind of mid-20s, but the age range did kind of go up to between 18 and 41. But most of them were mid-20s. A majority of them had never been pregnant or had a baby before. And around 34% of them said that they experienced urinary incontinence. And a lot of times it was maybe on the mild to moderate level of symptoms for them, but that's over a third,
That's a
around a
lot.
third,
Yeah.
which is a pretty pretty significant finding. And that is important to also position in relationship to other high-level, professional level, or elite-level athletes, is that it actually aligns a lot with what's been found in other sports with female athletes, that these really high-level athletes, at least around a third of them, sometimes more, experience leakage. Our main focus of that study was on incontinence, but we did ask other questions about things like back pain, irregular menstruation, which can kind of maybe be a factor that overlays, as well as the only pelvic pain question we did ask was an important one, was whether or not they'd had a history of painful intercourse. And around 40% or so, I'd have to look at the exact number, had reported that they'd had an experience of pain with sex. So a huge number. And we couldn't really extrapolate more on that because we didn't have a lot of follow-up questions. But that is something I think definitely is important to pursue. And there's not enough studies on pelvic pain in athletic populations at all. But the few that are out there have been on female athletes and kind of align with that as well, that pain with sex is a fairly common experience. And we saw something similar. I also worked with Emily Sherb and Heather Heineman on a study on female aerialists in circus. And we had over 400 aerialists, both recreational and professional, respond to our survey. I think we had 452 female aerialists, and over 40% of them reported leakage. We did have a higher percentage of those performers who had been pregnant or given birth. And the leakage was definitely associated with things like, pregnancy, history of birth, but also there was a correlation found between those who said they were leaking and those who'd had some type of fall onto the tailbone or some type of fall associated with training. We have theories on why that might be connected. So yeah, significant numbers also in our circus population, at least so far, and also very commonly an experience of pain with sex.
And I remember seeing a study looking at rhythmic gymnasts, and those athletes were quite young, and they reported quite high numbers as well. I remember being very surprised by that.
Yeah, we definitely have some data that shows in rhythmic and artistic gymnasts and cheerleaders, so kind of our ground tumbling folks. And a lot of that was adolescent age group, having high numbers of urinary incontinence. So something that's definitely starting potentially earlier than we think. I'm currently working with a couple of colleagues to gather information about pelvic floor types of symptoms in adolescent dancers, but we're still in the data collection phase. So we'll see what we find because we're very curious about whether we see that same thing in the dance population at those young ages, like what's been seen in rhythmic gymnastics.
So have you identified other risk factors besides the fact that they're a dancer or a gymnast, or, did you associate that with other risk factors when you were, looking at that?
We did look at some risk factors in our dancer study. And so what we pulled, or what we tried to explore, again, it was a survey study. So there were some limitations in what we could test for because we suspect that hypermobility is a factor. But that was really not something we could assess through a survey. But I definitely think that's something that is really warranting further exploration. In both the dance and the circus survey study, we did ask about irregular menstruation. And part of that was actually taken from questions in the LEAF-Q to look at energy availability and relative energy deficiency in sport. And because there is research that seems to be connecting low energy availability, fueling issues with an increased chance of pelvic floor dysfunction for athletes. So we think that might also be an overlaying factor. In fact, the International Olympic Committee a couple of years ago, I think it was 2023, but their updates actually included incontinence as a health consequence of REDS. That's something I think that's kind of this next exploration. We also know that athletes that do repetitive impact activities, there seems to be a correlation, and certainly dancers do. Certainly aerialists do, but they're in the air, so the impact, is not the same as the ground impact. Um, but I know that there's some sports researchers right now who have some studies out that are trying to collect data to kind of create more of a risk profile for the athletic population, and they're including questions that are relevant for dancers and that. So I'm interested to see what they find.
And do you think anyone has proposed, possible mechanisms for REDS contributing to incontinence? I'm trying to think of what the possible connection is there.
Yeah. So right now it's somewhat, still in the haven't proved it phase. But when we think about the consequences of REDS, particularly on skeletal muscle, that if low fueling is present, then that can just reduce the strength capabilities of any skeletal muscle if it's not appropriately fueled, and it can cause early fatigue. So the pelvic floor muscles are skeletal muscles. So if they're underfueled, they're kind of uh, subject to the same consequences. Um, and Other things like hormonal states are probably a factor, we think. Um, so if someone's in that prolonged low fueling, and let's say they're, a female athlete, that low estrogen state that could be induced if they're not getting their period or they're having irregular periods, which is not that uncommon in the dance population, um, that low estrogen state can affect sort of that continence mechanism, and potentially also affect the muscle capability. That's a couple of the potential reasons why. And the other reason, which probably could be magnified in people who are hypermobile, is with that low fueling, there might be more constipation, and constipation tends to exacerbate leakage or urgency, urinary urgency. And then for our hypermobile folks who might already have something like slow motility or GI issues, and then I guess that makes me kind of perhaps go on a tangent, but a lot of people with hypermobility have so many gut issues that they're dealing with that they may feel like they are on a very restricted, um, eating pattern because everything really triggers them. Maybe they haven't gotten a handle on how to help out their GI system. And so for an athlete, that has the potential to lead them to be underfueled as they're trying to navigate getting a handle on their GI issues. And then that underfueling could further slow down their GI system or create GI discomfort on top of what they already have.
Oh, that's so important. That's constipation, I feel like, is so common, and GI symptoms, like you said, are so, so common in the people that I see. And I see a ton of dancers, but I also see a ton of non-dancers, and that is such a problematic symptom. And low back pain, of course, is also problematic. So many people with pelvic pain, so many people that are struggling with this. I had a couple follow-up questions on incontinence before we move on to the next section. So first of all, I'm wondering if you can let me know, when you're talking about like 34% had incontinence or whatever, I'm curious two things. One, what's the background percent that you would expect in the general population? So kind of for frame of reference, so we could be like, oh, well, the average, population would be 20%. I'm making a number up, obviously. So if you happen to have that off the top of your head, and then the other is, how did you define incontinence?
So I Oh gosh, I hope I get it right, but I think some systematic reviews have shown general population maybe around a quarter of female population. So athletes sit in some senses higher, but I think it very much depends on the study, because in the general population, then people post, like if you compared people who'd never been pregnant, never had a baby, to people who have the rates are probably a little bit higher, because birth, especially vaginal birth, is a risk factor for increasing your likelihood of incontinence, and also age, peri and postmenopause. So, but I think some studies have shown about a quarter in the general population. So there is thought that female athletes might be actually at a higher risk. There's some studies that have shown, a 1 to 2 times higher risk of incontinence in high-level athletes compared to the general population. But again, I think it depends which studies you're looking at. So that's kind of interesting to try to solve this question of why are these really highly conditioned folks experiencing these types of symptoms. And I think you had another question that
how you defined incontinence.
So we used in both of those studies that I was talking about on the dancers and also on our aerialists, we used the ICIQUI short form, which
That's a
I got it right.
mouthful.
It's a mouthful. So it's a standardized, validated questionnaire to look at incontinence, and it's got it's not super long. So we selected that because prior athlete studies on female athletes and incontinence had used that. And so one of the questions basically asked, when does leaking happen? And that person who's filling out the questionnaire could say never. And then they could say sometimes, and they can start to list when that happens. So essentially, if they reported any kind of leaking in response to the ICIQUI short form questions, there's a particular question, and we aligned that with other studies that we'd seen. So based on their responses to that questionnaire, we stratified then into leaks and does not leak. And then we further asked questions that are part of the ICIQUI short form that gave us information about whether it was stress incontinence, which is if you leak when you're coughing, sneezing, exercising, and then urge incontinence, you feel a really strong urge to go and then you can't make it to the bathroom. It was much more common for our dancers, similar in our circus artists, to have stress incontinence. But in our dancer study, we didn't have a chance, though that standard questionnaire doesn't ask specifically for athletes how leaking is affecting their sport. So when we did the circus study, we kind of drew from the model of the dancer study that we had done. But we did ask questions at least about how leakage affected performance or training for our aerialists to get a little bit more information. And there's certainly lots of other validated questionnaires that are out there. So I think some of the newer studies on athletes might start to explore some other questionnaires like the Queensland. Yeah.
And as you're talking about that, I'm also thinking about, and I should have confirmed this with my husband or looked it up myself before we started this conversation, but I didn't. But I think that there's some data that show that teachers and nurses also have high rates of incontinence. And I think that what my husband had said is because they're holding it. They're on their feet all day and they're, not able to just go to the bathroom whenever they want. And of course, anesthesiologists also definitely fall into that category.
Yep.
So I wonder if with dancers, if they're in multi-hour long rehearsals, and athletes are also maybe once you have all your equipment on and things like that, there's probably some other factors as well that are at play.
Oh, sure. Yeah. Yeah. And thinking about that makes me also think about sort of the high pressure environment. You're talking about your husband's job. There's like a high pressure performance environment for our dancers, for aerialists, for other athletes. Not only might they be on kind of this timing that they can't control in terms of their bladder habits, but the pelvic floor region and our signaling system for the bladder is so dependent on our autonomic nervous system function. And so I think anyone can probably understand that if you are a performer, and especially in dance, if you're in concert dance and then they say places and all of a sudden you're like, oh, I have to pee. That's kind of a good example of how interconnected that bladder signaling mechanism is with our nervous system. And so if you're in these kind of high stress environments, high pressure environments that a lot of dancers, for example, are, I also wonder how that impacts that signaling system for the bladder for these athletes, and really for any sport.
Yeah, no, definitely. I'm glad you brought that up because, of course, a lot of people who listen to this podcast, and we do talk a lot about autonomic dysfunction. So there's a lot of people that have autonomic dysfunction, and that could play a role as well. And it's so funny that you gave that example because I remember sitting in a lecture with my urologist husband about bladder dysfunction. And I just suddenly felt like I had to pee, and I was like feeling all these sensations. You normally don't feel your bladder at all. So
Yeah.
I think that's a
Yeah. Isn't
very
that
good
interesting?
point. Yeah. Yeah. It is super interesting. Okay. So let's move on and just talk a little bit about the core before we're going to take a break. Um, I feel like, the core, like, and core engagement and what we're taught about that. Um, I feel like maybe we're getting some messages that maybe are not super helpful. What should we know about that?
Oh, I have lots of thoughts on it because I work with so many dancers. I also work with, I'm Pilates certified. I work with people that have trained a lot in the Pilates world, which is a lot of performers, as well as I see it a little bit in aerial work too. But since dance is kind of that center, um, I see so many dancers who are taught that engaging the core, or at least the impression that they seem to get when they're training, is that engaging the core is about pulling up and in their belly region, and that should be happening even if they're just standing there. Like that and sometimes I think this also is drawn from how picky we can be in dance, maybe to a fault, about people's alignment, or how people maybe bring those alignment stories with them. Like I have dancers like, well, I've told that I arch my back, or I've told that I tuck under, and so I'm trying to correct it all the time. And I'm like, how many years ago were you told that? And they're like, well, probably when I was 8, and they're 25 now. It's like, oh, well, you're probably fine, number one. And also, you're just standing there. You probably don't need that high level of contraction just to hold your body up. And I think that pattern kind of then, particularly, I know performing artists and a lot of athletes too can be really high achieving. So if you're going to have the impression that you should hold your core in, you're going to do it 150%.
Right, right,
And
right.
to make sure to not let it go. I mean, I still have dancers that are trained with cues that are like, I hold in your lunch, which has also got its own. I take issue with that
Oh
because
no. Yeah.
the belly doesn't always have to be pulled in. But I think what then can happen is when someone's really clenching their abdominal wall and are not taught that that can have some play to it, right? That during harder things, you're going to lift someone, or you're going to do something more challenging, and you need to stabilize your spine. Those muscles should naturally tense, but with lower level activities, you should be able to really breathe through it. So sometimes I think it restricts breathing, because if you're really squeezing in, then you're kind of holding your diaphragm in place. The diaphragm works so much with that pelvic floor that you're kind of missing the opportunity to get that cue of the pelvic floor lengthening. We also know that when people contract their abdominal wall, it usually co-contracts with the pelvic floor, which can be a really great thing for stability. But if the pelvic floor is kind of maybe taught to know how to really pull up and in, but you just don't practice as much of the eccentric or the lengthening or the relaxation, sometimes that can drive things like pelvic pain or urgency in particular, or even make leaking worse, because it can mess with that coordination function of that system. So I spend a lot of time telling dancers that it's okay to breathe into their belly sometimes, even while they're dancing, because for them, that feels ridiculous. The ones that feel like they're really good at pulling in, just so that they can get used to a different strategy.
Okay. We are going to take a quick break, and when we come back, we're going to talk more about the core and the pelvic floor and what kind of things we can do if we do have incontinence. So we're going to take a quick break, and we will be right back with Dr. Brooke Winder. Downtime at home should feel effortless, a quiet pause in your busy day. Cozy Earth's robes wrap you in softness with thoughtful details that move with you. I love the spacious pockets, adjustable ties, and cozy silhouettes that make every moment feel intentional. Each piece is made with such great care. And I also love their slippers. I love slipping my feet into them at the end of the day and finally exhaling. The footbed is so comfortable and makes my feet feel so amazing. They're really versatile, breathable, and cozy. I also love that Cozy Earth has a 100-night sleep trial and 10-year warranty, because the comfort you deserve should last just as long. Let this spring be a reminder that you deserve care too. Discover how Cozy Earth turns everyday routines into moments of softness and ease. Head to CozyEarth.com and use my code BENDY for an exclusive 20% off. And if you see a post-purchase survey, be sure to mention that you heard about Cozy Earth right here on Bendy Bodies, because home care starts with self-care. We're back with Dr. Brooke Winder, and I really appreciate what you're saying about the pelvic floor and engaging the core. And I've taken enough Pilates classes that, yes, I know that they are very much like, don't do this drawing your abdomen in kind of a thing. But it's so interesting because I've noticed dancers and they're standing in the back of the room, and you see a variety of things. You see people kind of hanging on their ligaments because they have so much hypermobility and they're so tired, you know. So they're just exhausted. So if they're not actually dancing and they're just kind of, waiting to go in the center or whatever it might be, or waiting to go across the floor. So whether you're a dancer or not, in terms of posture and, cues and things that we should be thinking about so that we are supporting our spine, or is there anything that we should be thinking about there that might be kind of a good tool for people?
Yeah, I think maybe if you are a mover who tends to kind of really be good at the drawing in part, or you tend to hold a lot of tension there, then sometimes a nice cue can be to actually maybe not be thinking about where the muscles are, but just stack your ribs on top of your pelvis. What does that feel like? So sort of like the imagery of where your bones are, rather than the amount of muscle tension. And I find that sometimes that can be helpful, especially, I think performing artists, we get so perfectionistic because that's how we're trained in terms of the movement, that if you give a muscle cue and someone's like, wait, am I doing it right? How much? And really analyzing that. And they're like, oh, just stack, maybe just more of, and sometimes that like an external cue or an image can be helpful. Or if they are supposed to be keeping their spine still and we're doing, core stability exercises, I really just kind of try to give them simple rules or set up the environment and kind of tell them your core is going to turn on. It's going to respond to what you're doing. So, if they're on hands and knees and wanting them to keep their spine pretty straight, like, can you balance this yoga block on your back and keep breathing and now move your limbs? And hopefully their core system should respond to that by turning on. So sometimes I like to give them the experience of what does that feel like when maybe you're just aligning your bones, or you're thinking about one simple image, or thinking about more task specific rather than exactly where your alignment needs to be. And sometimes then that needs maybe some more information for people who are hypermobile and might need more exacting to feel really good in their joints, certainly. Um, but I find that sometimes that can be an interesting exploration for dancers who haven't had the opportunity to train that way, to see if there's other cues that help them out.
Yeah, and I love that explanation or that example, I should say, that you just gave. And I know Jennifer has a lot of like great little things that she would at IADAMS, for example, the International Association of Dance Medicine and Science, when she would do workshops, and I've done some of those, and she would have people do, and I would try these like small little things that could be really challenging. So I think those kinds of exercises are really great because, you know, I think it's confusing sometimes because we can do so many great things with our levers, but yet that doesn't necessarily mean that we are having the optimal function of our pelvic floor, our diaphragm, our core. Is that accurate to say?
Yeah, I think so. And I would say likely maybe more accurate for people who have hypermobile joints, hypermobile bodies, because there's just more movement options. There's more options for positioning, and typically maybe also some reduced proprioception or feeling of where they are in space, especially through those end ranges. And so that's where, for someone who's more hypermobile in particular, it can feel really nicely challenging, or or maybe not nicely challenging if it's a really hard exercise. But some of those tiny adjustments or tiny little tasks to help that dancer find a new alignment or a new stacking, can be harder than you might imagine, but also can be really nice because it can give some information into your system that I think is really helpful from a proprioceptive point of view. That hopefully is easy for that dancer to then take into their class or their performance.
And what about the nervous system? What The nervous system and the pelvic floor, the tone of the pelvic floor, how are those connected and why is that important for people with hypermobility?
Yeah. So the region of the pelvic floor essentially, in a lot of ways, the muscles, they're skeletal muscles, just like your biceps. But what is unique about that whole region is that because we have our bladder and bowel function, our sexual function in that region as well, is that there's a lot of neural information or input coming in that is from our autonomic nervous system. So our fight, flight, freeze, and our rest, digest system really signals that region as it should to control our organ function. And the part of the tensioning and the relaxation of the pelvic floor is driven by those systems because when we have to have a bowel movement, when we need to pee, we need that coordination of the appropriate relaxation to happen. And then, we need the muscles to react really automatically. So I think because that's so closely intertwined with how our pelvic floor functions, and then if we have someone who's hypermobile and they're dealing with autonomic nervous system dysregulation, they've got something like POTS going on, um, that can be a big factor in how their pelvic floor region is responding, or maybe responding in a way that is not helpful if their system is dysregulated with POTS. Because even some of the symptoms of something like POTS could be feeling more urgency in the bladder region, feeling kind of like that continence mechanism is a little thrown off. So for anyone, whether they're hypermobile or not, any interventions that can help improve nervous system regulation can really help with the pelvic floor, with bladder function, with bowel function, with sexual function. But with someone with hypermobility who may be struggling with that kind of overlap with something like POTS, then helping them with strategies that manage the POTS symptoms can be a key way to help them with pelvic floor symptoms. Maybe even more so than like some bladder training program that I might give to someone where it's not that, where they don't have that complexity of what's going on with their autonomic nervous system.
No, that makes sense. And let's move on to sexual function. We've presented together on sexual and pelvic health. And how does pelvic floor dysfunction show up in sexual function?
Can show up in a lot of ways. In particular, I think on the pain side of things. So if there is dysfunction to the pelvic floor region, then that can show up as genital pain, vulvar pain, penile pain, vaginal pain, testicular pain, um, and and that can be due to a lot of different factors. There can be irritated nerves that can cause that. The pelvic floor muscle tension or non relaxation can also contribute. And then some of the other things I think we're going to talk about from the hypermobile standpoint. Um, and so, pain with sex and then pain with sexual activities that are non penetrative can be common. Um, also, can contribute to issues with arousal. So low arousal, also low libido can be very common as a factor when that system is not well regulated or is having trouble. And then on the maybe a related end that can have to do with things like mast cell issues, can have to do with things related to neural compression, but things like PGAD, where you have persistent genital arousal disorder, dysfunction, or that could even be due to other sacral issues that are contributing. But that can be a really, really distressing symptom that people can deal with as well. And then issues like incontinence or pelvic organ prolapse or bladder urgency and frequency can also interfere with sexual function as well, and contribute to people having lower desire, contribute to people having lots of different discomfort related to sexual dysfunction, and also just stress surrounding or maybe even shame surrounding that because they're dealing with pelvic floor symptoms that's affecting their sex life.
Yeah, and I'm glad you mentioned about PGAD and mast cell, and there's so much of this that, you and I, when we've done presentations, it's nice when most of the time we've had 90 minutes together, so we each have 45 minutes because it's a lot to talk about, and of course, then we have slides and everything, so it's really helpful to be able to, show with diagrams and studies and things. Yeah, the PGAD piece is really interesting because I know that there have been studies that have shown that PGAD, persistent genital arousal disorder, is more common in people with hypermobility. So I'm glad that you brought that up as well. So, what should rehab clinicians focus on when they're working with hypermobile patients to help them manage sexual dysfunction?
I think there's kind of a few big areas when it comes to working with people who are hypermobile. Um, Certainly, assessing the pelvic floor itself, if you're a pelvic floor physio, is something that's going to be a given no matter what person you're working with, whether that's external and or internal assessment. But I, with people, well, with any patient, particularly for people who are hypermobile, I really kind of think about zooming out to some big themes that can help them out. So one piece is really looking at their pelvic floor symptoms, as this like, why is their pelvic floor so angry? Why is their pelvic floor needing to hold tension, or why is it responding in this way? And then in that zoom out, one of the pieces I think is really important in rehab is then looking at all potential other orthopedic issues that someone with hypermobility could be dealing with. So people who are hypermobile are going to have potentially issues with, if we think nearby regions, maybe more issues with hip instability or femoral acetabular impingement, or other joint issues within the hip that could be um, a place where they need some stability and strength and support in treating that hip. And that allows the pelvic floor, just one of those little pieces that can allow their pelvic floor to function better. Similarly, with low back issues that are common in people who are hypermobile, there's a little higher incidence in things like if you think of low back sacral, Tarlov cysts, disc herniations. So, is their pelvic floor actually having trouble because of something more proximal that needs assessment? Or just even giving them the idea of stability elsewhere can be helpful. And even kind of zooming further out, issues in the cervical region. So people who are hypermobile might be dealing with things like upper cervical instability or just a lot of neck hypermobility that can be really distressing for their nervous system, kind of proprioceptively, and also cause a lot of tension to be held up here. And I know my pelvic floor physical therapist will know that a lot of times this tension and issues up here and clenching up here seems to correspond with the pelvic floor having a lot of tension. Very similarly, making sure to screen and help support things like jaw issues, with TMJ, gum issues, dental issues, anything in kind of that orofacial region that's more common in people with hypermobility that can cause a lot of tension up here that then can be one piece that's also driving tension that already exists at the pelvic floor. So I think that's a really big piece, is like that zoom out and thinking about all the different, I mean, it's kind of nice. There's lots of inroads that could help actually, even indirectly, that pelvic floor find a little bit better balance. And then kind of on this other big piece, I think, looking at lots of coping strategies and like things like pacing for patients with hypermobility and sexual dysfunction, or hypermobility and pelvic floor dysfunction. Because, people who are hypermobile might be dealing with a lot more fatigue or challenges in recovering after daily activity, and that, or sport, right? So I think helping them figure out how to work through patterns of when they might plan ahead for a time where they're going to be more fatigued, or they know they get really wiped out of these things. Because if you're really tired and you just don't feel well and you can't recover, that certainly can affect libido. And so I think I think helping those patients really try to suss out some patterns, which can be hard because it's hypermobility. I think I have a lot of patients where they're like, there's no pattern. I can't quite predict what's going to happen. But maybe setting up the things that they know they go to calm their system down, whether that's meditation or a heating pad or a brace. Like if they're going to be doing a more difficult activity and they know they feel better if they put a neck brace on, or they feel better if they have those support. Some of that planning, I think, can help them figure out then how to navigate coping strategies when it comes to sexual function, um, with themselves, with a partner. So that can be a big piece too, because some people who are hypermobile, I think we've talked about this before, might manage symptoms by actually kind of overdoing it. Like if their sensory system feels better when they just go, 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 or they actually feel worse when they sit too long or stand too long. Sometimes that might be driving people to do too much, and they don't realize that that's part of their kind of behavioral patterning, and trying to find a balance with that. Or if they're really, you know, having a lot of symptoms through movement, maybe they're not moving enough, and need to really find an inroad to get moving, just so that their body can feel more confident or feel more positive with movement, because that's an important piece with sexual function and pelvic symptoms. And then in terms of sexual function too, for people who are hypermobile, if you're thinking about strengthening programs, think about sexual positions that they feel nervous about getting into. Like maybe they might feel like, oh, I feel like my hip's going to dislocate, or I feel like my shoulder or my finger or my wrist. So, asking questions about that and trying to work with them in terms of like those exercise positions that might help them build more strength and stability and more confidence, so that they don't have to sit with as much fear about having a flare up with sexual activity, even not totally directly related to their pelvic floor, but related to their surrounding joints.
Yeah, there's so many things with hypermobility, and I mean, even just people who aren't hypermobile, the pelvic floor is I feel like it's so complicated, and like we hear this, oh well, just do more Kegels, but you're talking about the relaxation piece and how that you need to balance the stability, um, and the ability to activate the muscles with the ability to relax the muscles. It sounds like too. So how do you know where you are on that spectrum, and do I need more Kegels, or do I need to learn to relax my pelvic floor?
Sometimes we can tell most easily with something like an internal pelvic floor assessment, where we can really palpate a painful region, or feel that we can feel that the muscle, or see that the muscle is having trouble relaxing, and that can kind of give us a clue. But for someone like, if you're dealing with a pelvic floor issue, things that are more commonly associated with more tension or non-relaxation or difficulty relaxing can be things like pain, um, uh, pain with inserting a tampon, painful sex, um, frequent urinary frequency or urgency, or painful menstruation. Um, those tend to have more correlation with more tension in the pelvic floor, and also incontinence, but kind of look at like, are you dealing with these other things? As I mentioned, uh, with whether it's kind of more of a weakness driver, are you uh, pregnant or early postpartum, or postpartum if you've given birth? That's especially vaginal birth. Maybe you've had a very big stretching of that pelvic floor, and that strengthening piece is probably maybe a bigger first step after something like that, or a pelvic surgery. Um, that that's where we're going to see, or maybe you've had like a nerve dysfunction that has caused weakness, then that makes sense that that might be the first inroad. What's kind of interesting that I think we're going to, of course, because it keeps getting more complicated, but also we get more information out there, that there is, I think we kind of swung the pendulum in this way, where if someone has too much pelvic floor tone, then we kind of went in this direction of like, okay, well, stop kegling. I think you can know if you're doing pelvic floor contractions, it's making your symptoms worse. That's probably a good clue that you need to try a different route to start to manage your symptoms. And I know that seems maybe too simple, but A lot of people find that that doesn't make any sense. I'm doing pelvic floor contractions. I thought it was weak, but I actually am leaking more. So sometimes you could start with going, okay, well now if I try some things that foster relaxation, maybe learning some internal, external stretching or self-massage or yoga breathing or positions that give me relaxation, does that start to calm my symptoms? But what's interesting is we are seeing some newer papers, I think, come out in the last couple of years that are showing that we don't have to totally avoid strengthening with people who have pelvic pain, that Kegling can be a piece of the puzzle, but it's about trying to make sure that we are assessing someone's strength and length and ability to relax, and then finding maybe the first inroad to help them get their symptoms under control. And then as we are working, sometimes strengthening can help to decrease pain. But I think it's about kind of like what you're finding clinically when you assess someone and how they're responding to initial treatment to kind of help figure out that balance of strength and length.
Yeah, because the pelvic floor can be overactive or underactive, right? And can a person have it overactive sometimes and underactive other times? Is that possible?
I mean, it seems to be the case. And that's kind of like with what I was just kind of mentioning with, some people with pelvic pain are maybe benefiting from certain types of contraction and strengthening, even if they're already holding and maybe they're sitting in a tightened position, like an overly tightened position, that somehow that strengthening actually helps them learn to relax the muscle. So yeah, it seems to be that that maybe it's just not as simple, which kind of makes sense, right? Us as humans and the way our bodies move, it's never so, you're in one lane or the other. So I think that some people are kind of dealing with a combination of both. And if your muscles already so like holding so much, then it's hard to really like you're not starting at a great length tension relationship to get a good contraction. So in that sense, it can actually maybe sort of seem like it's presenting as underactivity because you already shut the door. So you can't, it's harder to shut it more, so to speak.
Yeah, no, that makes sense. And are there certain things that people should stop doing that they might be doing that are making things worse?
Oh, that's such a good question. I think going back maybe to the simplicity side, that if you have kind of you're noticing you've had pelvic floor symptoms and you had maybe assumed or just thought, okay, maybe I should start contracting my pelvic floor, and you're noticing that it's either not helping or it's making things worse. Um, Try something else. Try either strengthening the rest of your body or what we call down training and relaxing it. I think just because it sounds like it's supposed to work, if it's not working for you, it, maybe it's actually just not the treatment that you need. And maybe that's too simple of a thought. But I think sometimes you can think, well, like, this is so frustrating. It should work for me. I'm leaking. I'm probably weak. If I'm working on contracting these muscles, why isn't that helping? And sometimes it's about treating and helping every other aspect of the body to support the pelvic floor so that it can work more efficiently. Or sometimes it's about relaxing the pelvic floor or learning different types of coordination. So I would say that's probably a big one. Um, and then I think maybe this is maybe more on the clinician side, and I think we were going to head there. Um, but if you're really treating the pelvic floor and it's like kind of getting narrow and working on pelvic floor strategies, um, sometimes that's too focused on this region, especially for hypermobile people. Don't forget to zoom out because sometimes you could be trying to relax their muscles, but if they've got a POTS issue or a mast cell issue that's driving the pelvic pain, you can keep teaching them to relax, but really they actually might make some bigger gains if you help get support for them in those other health considerations that actually might be a bigger driver.
So you're saying that sometimes we can get overly focused on something like the pelvic floor when really there's other contributing factors and we need to zoom out and be looking at those other factors as well.
Yeah. Yeah. Particularly like I mentioned with the hypermobile population, there's inflammatory drivers, there's uh, a lot of GI system issues that a lot of times with things like leakage or urinary urgency, managing constipation can have a huge positive impact on reducing bladder symptoms. And so that can be another piece that just can be super helpful. And also managing kind of with a registered dietitian or looking at all the different supports that maybe are needed from a nutritional and nourishment side that might help the constipation and also help energy levels when it comes to athletes. I think that that's just another window to make sure you're thinking about, to see if that can really help that person.
And for people who are listening to this and saying, well, they just kind of sound like me, what's the first step they should take?
Um, oh boy. I mean, I think if if they maybe haven't started to find a support system for these issues. So if you're thinking that sounds like me and this is a pelvic floor issue, um, and you've never really connected with like a pelvic floor physical therapist, maybe start exploring what could that look like. Because a lot of times pelvic floor PTs are going to be looking at the systems surrounding that and can be really helpful, particularly. And I think if you're an athlete, like a dancer, a performer who is kind of resonating with this, um, working with someone who understands high level athletes that will look at the whole picture, I think is really helpful. That kind of can hear the mobility piece, the pelvic piece, and the fact that your whole body needs to really function at a high level can be a really helpful thing. So start kind of reaching out in your community, kind of looking at resources, even people that have been on your podcast and other places, asking around within the performing arts community, kind of like, and what's interesting on the dance side, I know lots of performing arts PTs now that are pelvic PTs. There's something about where we've kind of headed into that performing arts care. So for dancers, I'm seeing more and more kind of every conference we go to, there's more and more, at least on the PT side, where, yep, they treat orthopedic issues, high level dancers, and are also trained in pelvic floor, um, which I think is so cool and exciting. So just know that we're out there. Hopefully more of us are multiplying every year.
Yeah, I hope so too, because it's the whole hammer nail thing. So you only have the tools that you have. So the more tools you have, the more you can help somebody. So if you're trained in orthopedic physical therapy and also pelvic floor physical therapy, you're going to be able to offer, such a wider range of things. And don't get me started on insurance and
Hmm.
how, but you're treating the left ankle. God forbid you look at the right ankle, or God forbid you look at the left knee, or something. It just drives me insane.
I
Because
know.
for the insurance companies that are listening, everything in the body is connected. So,
So
so
true.
number one, everything in the body is connected, and number two, if there are any insurance people listening, please, please, please pay more for these other ancillary things that people desperately need. Like you'll pay for surgeries, you'll pay for outrageously expensive surgeries, but people need things like this. They need to be able to go to Pilates, and ideally have their insurance pay for it because it's for their health and it's going to help them function better, and it might save you a lot of money in the long run. But I know insurance companies are don't not looking at things that way. They're not preventative or anything. But yeah, that's something that obviously is one of my soapboxes. Um, Before we wrap up, can you tell me what you think is a big misconception about pelvic floor physical therapy that you want to take this opportunity to clear up, if there is any?
I would say for maybe potential patients, so people who are having pelvic floor issues and kind of thinking about what pelvic floor physical therapy is, um, I think one of the misconceptions that people can get is that it only or has to involve an internal exam of that region, which can feel really scary and intimidating for people, or it might not be what someone really wants to ever pursue. And I think that that can hold people back sometimes from getting an assessment from a pelvic floor physical therapist or physio. And so I think it's important for people to know that it is a method of assessing the pelvic floor muscles, but it is not the only way that we are assessing muscles. I treat lots of people virtually, um, and I obviously don't do internal exams. I'm not seeing the patient right in front of me. And we figure out lots of strategies to help the pelvic floor. And so, um, you have agency. You are the person who gets to kind of decide what is important to you in your care and what you feel comfortable with. And you don't have to have an internal exam. There's a lot of ways that we can figure out what's going on. And a lot of times we're looking at whole body function. Um, and there's ultrasound, there's external modes of assessment I think technology is continuing to help us with that give people lots of options. So just know that pelvic floor PT is not just about the pelvis, not just about internal exam. It really is looking at a lens very similar to what I would call orthopedic PT. So I think if more people can know that, and that you can find many, many, many pelvic physios who will work with you. And if you're not comfortable doing an internal exam, there's lots of ways to figure out what's going on.
And that's great that you can actually do it virtually, like we're doing right now. I'm in my home office. I don't know if you're in your home
Yep,
office, but
I
yeah.
am.
So yeah. Okay. Well, this was such a great conversation, and I know that you know that we like to end every episode with a hypermobility hack. Do you have one to share with us?
Yeah, I would say if you are hypermobile, just know that even if you have a ton more mobility and maybe some connective tissues that don't respond the same way as other people, that you can get strong. You can perform at a high level if that's something that you want. I think it's about finding sort of the right recipe for you and figuring out how you feel best supported and how you navigate movement. And that sometimes can be about slowly building a team that supports you, and figuring out little bits of something here and something there that can help you feel like you can take your movement to the next level, no matter where your level is to start with.
And I think I've told you that it was listening to you in one of our talks together, and you were saying something about sometimes having weights actually helps with proprioception. And I kept thinking that I had to be like really good at doing my weight training class with just arm weight before I could hold any weights in my hands. And then after listening to you say that, I thought, I think I'm going to try to start using, light weights. And it did seem like it helped my proprioception. And of course, helped me get stronger faster. So I really have you to thank for my, actually making some progress in that direction and actually building some muscle recently. So thank you.
Yeah, that's so awesome. And I think it's important to know that even if maybe there's these other factors that tissues respond to load. So load can help improve resilience of our tissues. We just might have to tweak kind of how fast that happens or how we recover. But it's often helpful, and like you said, helpful on the proprioceptive end. Sometimes I can be giving a million cues to someone about their alignment, particularly if they're hypermobile. And then I'm like, oh, this isn't helping. I'm not giving them helpful feedback. And if I hand them a weight, their body figures it out because they've got that kind of maybe axial or compressive load that just helps their body figure out what feels good to them.
And this is where it's so tricky because, it's so common to have kinesiophobia when we're hypermobile, right? So we're afraid to move and we could get injured doing small little things. And it's ironic. I mean, I've injured myself doing small little things, but now I'm going to this weight training class 3 times a week. And I've, knock on wood, been doing, well with that. So it can be so tricky to figure that out. But I think no matter what, you need to have a certain amount of load, right, on your tissues, whether you have a genetic connective tissue disorder or if your connective tissue isn't functioning as well as you would like it to because your immune system isn't functioning optimally. But either way, right, we keep needing to do some challenges on our bodies, right? Because otherwise we will get weaker. Is that correct?
Yeah, I mean, I one of the biggest things that seems to, if we really distill down, exercise as an intervention is really helpful in so many ways. And the magnitude or the intensity of that can be scaled, obviously, but our tissues need some type of stress. Not all stress is bad stress. And we need some type of stress to keep that stimulus for our bone health, for our muscle health, and for our connective tissue health. Um, and and it is like I find with the dancers that I work with that are hypermobile, sometimes they can be doing these really high level things in their class and their performance. And then they're like, what really threw me off was sleeping because they were in a passive position. And and that felt actually more uncomfortable than when they are getting that stimulus for all their muscles to contract around their joints and support them and that feedback for moving and also the joy of movement. If you can find something that gives you a little bit of joy or is kind of fun, and it can feel good to make that little leap or that little accomplishment in feeling a little bit stronger.
Yeah. And I realize as I'm saying that I also want to acknowledge that people who have post-exertional malaise, that can be very, very tricky to figure out, like, what can I do? And I'm not saying that everyone should go do a graded exercise program because I know that can really set some people back. But those are often like, prescriptive, right? They're like, do you do this, then you do this, then you do this. And we really need to individualize things and make sure that we're meeting people where they're at and helping them to move as much as they can, because otherwise it seems like it just, turns into sarcopenia, muscle loss, and, other suboptimal things like, dysfunction of the autonomic nervous system. Not to throw that in at the very end, but I just realized after I said that it could be misinterpreted by some people.
Yeah, 100%. And I'll kind of put the lens on that I work with a lot of hypermobile folks that are high-level athletes, and I acknowledge that is definitely not everyone's experience, if you're dealing with a hypermobile issue. And maybe your goal is like, I need to get out of bed today. So that moving more like is so scaled so differently depending on where you're at and what your needs are and what your symptoms are and your conditions are. So yeah, I definitely agree. I think that's such a good point.
Yeah, and thank you for saying that because it's so true. That's why I really, bendy bodies. I've every so often I've thought about, oh, should I change the name? But really, I want this to be for anyone who has hypermobility, whether they are a high level performing athlete or if there's somebody who, they can't get out of bed. They have so many things going on, and of course, there's massive differences between these people, and science hasn't really caught up yet. But hopefully, we're making some progress to figure out, like, why do people look so vastly different from each other, yet they also have some similarities, right? So, well, this has been a fascinating conversation. As always, I love getting to hang out with you, and it was fun to get to do this.
Yes, thank you so much. It's so great talking with you.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at hypermobilitymd. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.